psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow! Welcome to the Good Shrinks podcast, or maybe not so good shrinks.
What makes you say that?
Just a vibe I'm feeling today. We'll see how this episode goes. How are you, T?
I'm okay. I'm doing all right today.
That's good.
Yeah.
Me too.
It's hot. And we've had a lot of storms lately, you know.
I know. It ties into our last episode.
I was about to say flashback.
Right? But we know it may not mean much, right?
Yeah.
But I say, tied with summer, things tend to slow down a little bit for us, which is nice. And I think today maybe we'll talk a little bit about our role in emergency psych, kind of things we enjoy, things that we find difficult, and even how it sort of ties into the community. What do you think?
I think that sounds like a good idea. Let people know what we're doing out here.
Yeah. I was thinking some of the frustrations, and I don't want to make this episode necessarily to a point where it's negative, but we do have a lot of frustration of acute crisis centers really have become a mainstay for treatment because there is sort of a lack of community services. And so we've become a staple for that.
Like we talked in our other episode about deinstitutionalization, where do people go? I mean, it's good that we're doing this because it sort of lets people know that there is a place. If you do need to talk to somebody, you can get immediate access. But the resources are just not out there.
Yeah,
a lot of times.
Looking at sort of stats in our state, if you were to guess, what number in the United States do you think we are in access to mental health?
Ooh.
It's not good.
35.
44. Okay, we are down low, and I think
That's out of 50, y'all.
Soon to be 51 with Puerto Rico. No, I'm just kidding. But honestly, if you think about that, I think that's sometimes like why we have people boarded for so long and why we sort of deal with some of our internal frustrations at work, because there is a lack of resources. Mm-hmm. And honestly, mental health evaluations have only gone up. Mm-hmm. Since 2010, in our state, there were about 50,000 involuntary commitments a year. Mm-hmm. And then in 10 years later, in 2021, how much do you think that's increased if you were to take a guess?
10%?
It's doubled. 100.
200%.
Yeah, well, yes. So it went from 50,000 a year to 100,000 a year. I mean, that's a twofold increase, And I think we feel that at work, right?
I think we definitely need to do an episode on involuntary commitment. I
Yes.
feel like that would be educational and also probably therapeutic. Just talk about it.
I agree.
But yeah, wow, that's amazing.
Yeah. And
100,000 people. Now, that doesn't necessarily mean 100,000 people got admitted to the hospital. That means 100,000 people were brought, extra people were brought to the emergency room to have an evaluation.
For an emergency room evaluation. And as we know, in the medical emergency departments, even if someone's coming in for, let's say, a physical complaint, there's over 40...
Headache, stomach ache.
Yeah. I mean,
But then with a side of suicidal thoughts.
A little something. Well, that's kind of what I'm getting at, is there's over 40% of them have a mental health substance abuse issue. There's always an underlying involvement there, and the medical EDs feel it, and they're not great places to board patients, right?
Yeah, because they're dealing with medical crises, and then you've got somebody screaming or, unruly or agitated. It definitely disrupts their flow.
Yeah, I mean, it takes up a lot of space, and kind of looking at even time to inpatient, right? So back in 2018, it took about 180 hours on average to get inpatient. And that's just in general between adults and children. Now it's closer to 400 hours, which if you think there's 24 hours in a day, people are boarded for a long time before they get into the hospital. Mm-hmm. And I think that ties back to our deinstitutionalization episode, like you were saying. I mean, there's such a reduction in state hospital settings. I think a lot of hospital systems now don't place a lot of emphasis on new inpatient psych units, mainly because it's not really a revenue generator. And at least in our state, we feel it.
Absolutely. What are some of the things that you like about the emergency room system?
So I think for us, we have sort of more of a dedicated emergency department, right, for mental health
It's
crises.
rare. It's rare. It's really a jewel.
Hmm. And I think one thing I enjoy about it is we have such a broad spectrum. We see everything from just someone with depression to severe cases, people with dementia that are agitated, group home individuals that are struggling, people that are truly suicidal. I mean, I think in the past 6 years, I've seen literally just everything.
Everything in the DSM. Personality disorders, substance abuse, like you said, children, geriatric patients. We just see the whole gamut.
Yeah, and sometimes I feel like we really do make a big difference, and then other times I get frustrated where I'm like, oh my goodness, like what are we doing here? I'm like, our society is like crumbling.
We really have to guard against what's the word? Entropy? Like, just sort of not just getting sort of numb to it. Like there's just this cycle and we're seeing the same people and, what is really changing. And we can be frustrated or discouraged by that. We have to remember you never know when it's going to be that day for that person that you make a breakthrough. So you keep trying, but it's very hard to fight against that feeling like, are we really making a difference?
I mean, you bring up a good point, and T, you are so good at that. Like, you always have such a positive energy. You do, even if you're, like, in the throes of it. Like, I feel like if you were on a spaceship and, like, things were going haywire, you would still be, like, the most calm person on that spaceship.
You'd be surprised. You'd be surprised. It's easy to think about it. It's sort of like, looking at it from stepping back and looking at it from a bigger perspective. It's easier to see things, but when you're right there in the details of it and the crush of it, it can be very challenging. I definitely have, times where I lose it.
Yeah, and I mean, yeah, for sure. I don't know about you, but I know for me, sometimes I use like a little bit of dark humor to cope. I think we all do. It's like if I worked many days in a row, then I start going to a place of like, oh my God, this kid's not suicidal. He just didn't want to take his test,
He wanted his phone back.
Yeah, he wanted his phone back, and everyone's freaking out. Or, like let's say someone says they're suicidal, but it's like, no, your boyfriend or girlfriend broke up with you, and you're upset. Like that's what's going on. You have to like kind of stay as neutral and positive. Like in a sense, for the patient, we always do in the room, but it's like you do have to maintain that neutrality. And I notice like if I do skew a little bit more towards like hurrying, and not allow the person to sort of express themselves, like it does.
I definitely have done that.
Yeah, and it changes the dynamic.
Like, because pretty much I kind of have decided before I go in the room what I'm going to do. After I've read the note, I mean, it's very rare that I'm surprised during an evaluation. But it happens. Sometimes you go in thinking one thing. That's why it's good. It's good to read the note and prepare yourself before you go in. But at the same time, sometimes it's good to just go in fresh.
Yeah.
And just sort of take what you're getting to get a better kind of perspective and leave that kind of jaded, cynic, part out. That skeptic part, just leave it on the shelf.
Exactly.
Not too far, but, so you can really hear them with fresh ears and see what's different today.
Yeah, I mean, in a sense, that's how you build rapport and a relationship with the patient, and, really in the emergency department, like for us, our evaluations should be more focused, right? So we're checking to see if there's a medical emergency. We're checking to see if there is any suicidality. We're checking to see what is the lowest level of care that they can function at. Everyone wants to be inpatient, but sometimes it's like, is that what's going to help you the most, Right. And then also like determining the right community resources. And sometimes individuals and I get it, like sometimes it can take a long time to get into therapy. I mean, they'll come in and want to use the emergency department as a therapy session. I know for me, it's like, I'll come in, we can do a little bit of therapy, but I don't know if you noticed the waiting room. After you, there's 20 more people waiting to be seen. Like, this may not be the place.
I mean, like last night, I was seeing a patient, and I thought it said on the board, med refill. So I thought, okay, I'll get one more in before I go.
Yeah.
So I go in, and I sit down and start talking with her, and at the same time, another patient comes in, and she's autistic, and she's very, very limited, like intellectually. And she just starts wailing. And this is something, her mother brings her very often to the emergency room to get her behaviors under control, because it's hard to deal with her in the community when she's, agitated. So this is going on, and I expected the patient I was talking to start to feel. I was actually surprised she was still out there, when I went to go talk to her. But instead, she leaned in and talked about why she was there, and it escalated to the point where I ended up having to admit her.
Oh, wow.
Because she actually had, suicidal thoughts. She sort of minimized it a little bit on the triage. But as she was talking, some of it I was wondering, was she getting more agitated herself, more labile, what we call that when you start having lots of different emotions. So you just start crying, then you start screaming, then you might laugh, just a rapid shift in emotion. So I thought maybe this woman was agitating her because she was getting more upset herself. But no, it was she had been keeping things to herself for a long time, lots of trauma. Was being triggered by things going on in her life at the time, and she's like, I really just don't trust myself. We talked about, one of the things we do when we're deciding about risk is start to figure out what's a safe disposition plan. Like you said, what's the lowest level that, is this somebody I could send home and feel like we could put things around them to support and keep them safe? And she could not list really anything. And didn't really want to stay, but as she was talking about it, she was like, I can't say I wouldn't do something if I went home. I mean, maybe I would just go home and go to sleep, but I'm not sure. So, sometimes these evaluations go sideways. It's not what you expect.
No, it's really not. Oftentimes we joke about that because, in our emergency department, there's two areas, right? There's the outer lobby, which is considered lower acuity and that you are able to maintain your safety. And then there's the secure lobby where there is a locked area. And so you're held there until you have your evaluation due to safety concerns.
So you don't leave before we figure out how unsafe you are.
Exactly. And, we always joke about how sometimes the simple med refill outer lobby patients are like the hardest because they will change the evaluation. Morph.
Into an emergency.
Yeah.
But it's good that you get that information. I mean, the worst thing is for us to have missed an opportunity to help somebody who was really in need. So I'm glad that she opened up and was honest about how she was feeling.
Yeah. And I think it's good we have like kind of an area where people can be held overnight to, in our emergency department, there's kind of like 3 levels of care. It's like we have you follow up with outpatient, maybe appropriate intensive outpatient program or a resource that we know of. We keep you for 24 hours and see how you're doing and see if you're able to reconstitute, right? So if let's say you come in high on drugs or there's a conflict and you don't really think it's going to need an inpatient stay, then we can kind of hold them. And then there's obviously then starting the process to get them in the hospital. It's great that we have that resource. At the same time, it's interesting because that resource can be over and underutilized, I feel like. So sometimes individuals that know it's there, they'll come back, they want a place to stay for the night. Then you have the other spectrum where people are like very affluent, used to very nice things. They end up in the observation area. I mean, we're talking. There's
sleeping on a cot.
Yeah, once you go from sleeping in a nice bed to a cot, I mean, you're probably not going to love that.
Try to focus on why you're here.
Yeah,
not the accommodations.
Yeah.
This was your emergency, remember?
Yeah, exactly. I know, because soon after, I have it happen all the time, where once someone goes back there, they're like, opens their eyes a little bit, they're like, actually, I'm not that suicidal.
Perspective.
Yeah, it's like, well.
And that's good too, right?
Yeah.
Sometimes you realize it's not as bad as you think.
Yeah, 100%. I had a lady not too long ago, and this happens all the time. When she came to the back, she kind of started giving me more reasons she wanted to live. And it's like, well, okay, well, we're still feeling the same way tomorrow. Maybe you don't need to be inpatient. We can get you home, and that can be, I think it's just a little bit of an eye-opener. And in some sense, I try to think of, like, it may not be the easiest place to be. We try our best to make it as comfortable as possible. I mean, I wish it was I wish we had, like, individual rooms with super nice beds. I mean, obviously, that comes to funding and other things, and we can only do what's, like, really within our control,
Yeah, I was just thinking, why can't we have that? Why aren't mental health patients more valuable? I mean, it's not like the medical emergency rooms are that much more, but they have actual hospital beds there, They have equipment and things like that. And, we don't need that same kind of equipment for our patients, so I'm not advocating for that. But, just a little bit more sort of a nod to let's make this very uncomfortable patient as comfortable as we can while they sort out what's going on with them.
Yeah.
I wonder why that's not a priority.
That's a great question. I mean, I think part of it does tie a little bit back to our deinstitutionalization episode and kind of where funding goes.
I mean, how do they think people can function if their mental health is not? How is this country going to continue to grow and function if the participants aren't well?
Well, I think for us as mental health providers, I get a little bit frustrated when on the news the politicians are like, it's a mental health issue, it's a mental health issue. Well, then how about you give us some resources?
Right.
Because literally we're working with bare bones.
Talk about it.
Yeah. I mean, let's keep it real. It's like, oh, gun control, it's a mental health issue. I mean, I see no money coming our way in any way, shape, or form. We're like a scapegoat at the end of the day. And it's really frustrating for me.
Yeah, I hear you.
But yeah, I agree. I mean, I think that's a good point. And I think it'll ebb and flow. At some point, mental health, and it has increased in awareness, and maybe it'll take time to sort of for that to filter more into policy, hopefully. Maybe I'm being overly positive, but maybe, right?
Maybe we'll have a St. Jude's program for the mentally ill.
While we're kind of on this down and out, one other...
Just speaking the truth,
right? This keeping
truth,
it 100%
yes.
real. All right. Something else too is even on the west part of our state, right, the western portion of our state, the time to even get just individual therapy is so insane. We're talking 10 to 12 week wait list for just outpatient treatment.
What do you think is going to happen to that person in 10 to 12 weeks?
Exactly.
Do you think that's a good, but again, is that because of the lack of therapists? There are just no bodies doing that work, which is why, telepsychiatry has become such a booming, thing, is because we can reach more people, more area with fewer bodies.
Yeah, I agree.
And they really appreciate that, the medical emergency rooms were getting completely overwhelmed. I mean, imagine what it's like now, as busy as it is, but with no psychiatric outlet. So people would there's no way to clear people. If you're not certified in that field, it'd be like me trying to clear a heart attack, patient.
Yeah.
I don't have necessarily the tools to do that. So this person just stays in the emergency room until somebody feels like they're safe enough to go home. A family member comes up and says, okay, I'll take them home. But there's no psychiatric contact. So that has been a godsend, to a lot of these, especially rural and, just sort of remote areas that don't have psychiatrists. In the county.
Yeah.
They just don't have them.
Yeah, I mean, I agree. It really does extend kind of our arms and ability to reach individuals that would never really have contact. And honestly, sometimes you see those patients and they're sicker, right? Because they've gone longer without mental health treatment, and you're like, wow.
Right.
And it sort of makes me think too, when you're bringing that up, mentioning having ability to obtain an evaluation and, let's say, get medically cleared, psychiatrically cleared. I mean, even within our city, it's interesting. I don't know, I'd like to hear your perspective on this, T, but we get a lot of sort of cover your A, CYA consults, where, let's say, kids at school, they express some thoughts of harm. There's no really in between. It seems like the teacher, the parents, the school counselor sometimes do sort of bare minimum and just send us for an evaluation for clearance. And I have no problem doing it. Those are easier consults even for us, but it's also sort of depressing for me when I'm like, who's talking to the children? Where are the parents? Who asks, are you actually going to hurt yourself? What is going on? There's sometimes I feel like there's no in between. I'm like, it's almost
an automatic knee-jerk.
Yeah, a knee-jerk reaction.
I think because of the times that we live in and all of these school-related tragedies, ever since then, just in Columbine, all of the school shootings, and then it definitely didn't have anything in place at that time. Nobody even really thought that could ever happen. And so now schools are looking at what do we do when we do see any kind of, mention of danger. And I think that's just part of their protocols now.
Yeah.
Just they have to send, because if they don't and something happens, then it's going to reflect on them. So, we're sort of in the
Yeah, that's
catchment
true.
area for that, because we're an emergency room, so anybody can come at any time. So I
Anytime.
think that's just part of their
Protocol now. Yeah, that's a good point. I mean, I guess society has become more aware and even more dangerous. I
more
hate to say it.
dangerous.
Yeah. So it's sort of like they need us to clear them, and sometimes for us it feels like this is almost like a waste of an evaluation. But then,
But every now and then you do find a child that is really disturbed.
yeah.
And
Yeah.
you so I'll be interested in the incidence and prevalence of how many people that actually come to a psychiatric emergency room needed to come or needed follow-up after that.
Well, and we do find things like within their family unit that we can work on, like if they have an underlying mood disorder. But I feel like sometimes, I mean, that we do see those things for sure. I would say it's like on the lower end. But then sometimes it's like the parents are like, look, they just made me come here. And it's like,
no interest.
And the kid's like, no, I'm fine. And you're like, okay. And then like you talk about things with the parents and they're like, wait, we don't really have any issues. I'm like, okay, well, this was easy.
I mean, 5, 6, 7-year-olds, really?
I
You think
know. We're worried they're going to do something, but I guess it's just the times that we're in, So I think that shows for us things that we deal with that it's more of a societal issue, and then it just kind of, we're like the wastebasket for it in a sense. But I guess kind of speaking about that, like for you, T, is there certain, let's say, cases that you find easier or more difficult for you, like just for you personally to deal with in the emergency department?
The hardest cases for me, technically, I feel like, are geriatric cases. Because by the time the patient has come in and they have a symptom, they could be depressed, they could be confused. There's like 100 things it could be.
Yeah.
Immediately. And so you got to run through that list, especially if they have a lot of medical problems. So those take a lot of mental energy for me to just try to work back through what the differential is, what we think these problems could be. So they take a lot more time, especially on telepsych too, where you don't have as many sort of resources. You don't have somebody you can just say, hey, can you call this person, that is right there with you in the office.
Yeah.
So those cases take a long time. I've had a few geriatric cases.
T, I feel like you're being a little bit nice about that. Some of the cases we see, they're coming from the nursing home. They're
on the stretcher.
They're aggressive at the nursing home. The staff is done dealing with them. They dump them in the emergency department. Yeah. They really do. And then it's like, they're like, especially when they're just alert and oriented only to themselves. They have advanced Alzheimer's. It's like, they're like, they need inpatient treatment. I'm like, what are we going to treat?
It's not a psychiatric illness.
No.
Dementia is not a psychiatric illness, y'all.
Yeah, we'll treat the agitation,
symptoms,
and even that sometimes I do the best I can to make recommendations, but it does feel a little bit hopeless when you're like, this person has advanced dementia. It's really more about the staff having difficulty tolerating them. And usually, sometimes these individuals are already in a memory care unit, and you're like, what more do you want me to do?
Yeah, and if they have a psychiatric illness too, then that's something we can do. But when it's just straight up dementia, 85, 86-year-old person with advanced dementia, we really have to just say that there's no psychiatric emergency at this point. This is somebody that needs to have more monitoring at home or at the facility.
I mean, sometimes, to go my little tirade here, sometimes the nursing home staff will be like, this patient was kicking, punching, doing backflips. I'm like, this person is bedbound. I'm like, what? How are they doing all this to your staff? Really? I'm like, okay. You know what I mean? And I think that's one thing with us being investigators is we kind of read in between the lines and kind of I've gotten pretty good at getting a sense of what brought you in today, And
what was different today?
Yeah, and sometimes those are the more frustrating cases, I feel like, where I would say younger adults that are still somewhat enabled by parents can be difficult because I've had numerous cases where individuals are in residential treatment, they're in 2 or 3 inpatient hospitalizations, they leave one inpatient hospital, the parents send them to another, they come to our emergency department and the parents are demanding inpatient for more of a personality component.
Right.
And that can be hard because it's they have received treatment. They've received many kinds of treatment. Are they utilizing their coping strategies? Are they personally invested in their mental health treatment? because it seems like the parents are more invested than the child, and not even a child. Usually they're a young adult. So then it's like having those conversations with the parents, being like, what is your, and those are the hard conversations to have, is like, what are your expectations? Let's like make them a little bit more realistic, you know, and how involved do you want to be with this young adult? Because they're going to continue to self-harm. Like,
time to clip those wings.
Clip the wings a little bit.
Not clip them, actually let them fly.
Yeah. You know, because sometimes you see these individuals that are like 24, they've never worked, they lived at home. Parents are just really doing their best to get their like mental health treated. And maybe I'm being a little bit like harsh, but I'm kind of like, well,
you had a tough case this week, didn't you?
I did. Yeah. It's coming out right now.
Yeah, it's okay.
I'm sorry.
Let
I just
it out.
Because it's like, you know, I just want. And
this
maybe,
is the whole point.
Maybe
this is how we cope. We have to talk about it.
Yeah.
Yeah.
But I feel like I've had numerous of these situations, and it's kind of like, you know, you want to have some real talk, and then also you have to like kind of check yourself, you know.
Yeah. It's a lot of work.
It is.
Like, it's not just writing prescriptions and saying good luck. We are really trying to, you know, talk to people where they are, and it's not always easy to figure out in an emergency room setting where people are.
Yeah.
And how they can process what you're telling them.
Yeah.
If they're even in reality, you know. So it definitely takes that skill of knowing like when to say what, when to not say something. And yeah, that's something you hone over time.
Yeah, I agree. But I guess in some sense too with the emergency department. So like that's one way we cope is kind of using dark humor. We talk to each other, kind of decompress and process, vent, and also to bring some perspective. Like, am I seeing this in the right way? You know, which is nice about where we work.
Right, and we have a lot of smart people where we work, so we can also get a lot of advice, consultation about cases, especially children cases. There are so many medicines out there for like ADHD, just for example. And it's sometimes hard to keep up with all those new, you know, things. We go to conferences and we do continuing medical education so we can stay current. But things are, things happen quickly sometimes in between those conferences. So it's good to have that, you know, those resources of the people who are experts in those fields that you could just ask a question if you need to.
Yeah.
Yeah, I really love the people that we work with. Everybody has a different personality and different strengths, and we for the most part, I think, work together well as a team. We're very responsive to each other. I think, you know, there are always outliers in any business, but I feel like for the most part, they work hard together.
I agree. I don't really
and work well together.
Like even the outliers, like I can't really think of any. I think we all kind of fit pretty well, you know, which is nice. And we try to stay cohesive because it is a little bit of like, I mean, when we're in the trenches, we're there, you know.
We're soldiers. Yeah. We're out there fighting, you know, these battles.
So, yeah, I agree. Kind of going back to the main topic is like, you know, kind of our workflow. So we got a little bit off on a tangent, but that's okay. So, like, T, when someone comes in, right, like how sort of do we, stratify, or what do we do in a sense?
So what we're always trying to do is assess risk and find out why people are there. So usually, you know, they come in, they register. There's a nurse that will greet them and talk to them about why they're there, to get a triage, kind of get just a snapshot of why they came in. Then another nurse, sometimes the same nurse, will do a fuller assessment to get more details about the crisis that they're in, the stressors they're under, and some just sort of, and if they came with somebody, we might even be able to get some collateral information. So say it's somebody's mother or best friend comes in with them, we want to talk to them about why they accompanied them today, what their concerns are. Then the nurse communicates that the assessment is done, and then we pick up the case and go introduce ourselves and then get even deeper into why they came, and then we have a conversation. So those conversations can be 10 minutes if it's just or 5 minutes if it's just a med refill. But we're trying to gather information. I know for me, and I think everybody's different, you know, looking at the notes, but I want to know something about the reason that they came, the duration, how long they've been having symptoms, what the symptoms are specifically, because there are different criteria based on their answers that would help me decide, is this a mood disorder? Is this a thought disorder? Is this an anxiety disorder? So their answers to those questions will help sort of guide me in terms of what diagnosis and then, of course, treatment plan I might suggest to them. And we're talking about, why they're there. I also want to know a little bit about their past psychiatric history, kind of what treatment they've had before, what medicines. Have they ever attempted suicide before? Have they ever tried to hurt anybody else? Have they ever been hospitalized before? What medicines have they tried? And did they take them for, the actual length of time that they might get a good response? Or did they quit for some reason? Were there side effects? So there's lots of different questions there. I want to know about their family psychiatric history, because we know some things run in families. So if they have a lot of mood symptoms and we find out that their grandfather and mother had bipolar disorder, that might lead me to a certain direction. And also if there are family members that have attempted or committed suicide.
That's a big one.
That increases the risk that this person might, commit suicide. So I always want to know about that.
I think for me too, that's something that, if I'm on the fence about someone and if they tell me they've had a family member that committed suicide, I'm so much more conservative with treatment. I'm like, you probably will have to stay for a little bit, just because, if there's that impulsivity, or even if it's in the family, it's just such a higher risk,
Agreed. Then I want to know about their medical problems. Like, do they have any medical issues that could be contributing to this presentation? Like if they have thyroid disease, or if they have multiple sclerosis or cancer, those things could weigh into why they're having a mental health crisis. I want to know about their social history. I want to know who they live with, how long, are they getting along with their partner? Do they have children? Are they working? Do they have legal problems? Are they in the military? All of these little snapshot questions give you a bigger picture.
While you're sort of talking about those things, it's sparking memories. And honestly, some of my favorite consults are on telepsych, when you have, let's say, elderly people that have a lot of medical comorbidities and they've just become frustrated and want someone to talk to. I don't know why. Sometimes just talking to those little old ladies for a little while, you can tell it makes them feel better. You feel better. It's it's just a nice consult sometimes, and it seems like it's just kind of like you feel like you were helping them in the moment, because they do need someone to vent, because they've gone through so much medically, and that you don't really necessarily in our system always get a lot of support besides the actual treatment. So it's I kind of like those consults.
I think any consult where you feel like at the end of it, they got helped,
and
you also either
you
got helped yourself,
yeah,
or you felt good about being there for them.
Agreed. And also when you're talking about that, it sort of made me think
the worst ones are when the parents curse you out because you're not admitting their child.
Yes, which happens a lot. You're like, oh man, those are always the toughest.
Yeah, they're tough.
Because
because they're struggling, and you see that, but we're not. It's like a round peg in a square hole. Yes, the peg is there. We understand there is a problem, but we're not the resource to get you the help you need.
Yeah,
those are hard.
Those are really tough, because a lot of times, oppositional defiant disorder, conduct disorder in kids. So basically, these are kids that are super defiant towards authority. They will run away. They will curse out their parents. They will
break laws.
They won't go to school. And, these parents will come with this, laundry list of all these horrible behavioral things. I think as a whole we do a good job, and we're conservative. But even if, let's say, they do go inpatient, which technically a lot of them don't necessarily benefit from, when they go home, they're in the same environment, and there hasn't been a lot of change. And so it's really making sure they get involved in family services. And that, for me, is, I'm noticing more and more with parents, they're trying to get them into services, and it's there's either a long wait list, or they can't find the right provider,
or they have the wrong insurance, or their Medicaid doesn't cover this particular, intensive in-home. Or
which, doing a little bit of research for this, did you know that private insurance usually pays 80% for children of what Medicaid pays?
Wow.
I did not know that.
Well, I knew Medicaid probably paid more, but I didn't realize it's only 80%.
Yeah, so for children, it seems like, we kind of know this in practice, that Medicaid's the better option of the two.
For children, for sure.
But yeah, I agree. It makes it a little bit tough because like I really do validate the parents. I'm like, I know there's a lack of resources and you're trying, and so really they do kind of resort to us at times because it's like this is the only thing I know to do.
Thank God we're there.
Yeah, honestly,
Some days,
yeah,
it's
for
really,
sure.
it really makes.
Because some of the kids, I'm like surprised when they're the parents will say like they haven't been to school in like 3 months. They just refuse to go, and I'm like, how is that?
What?
How is that possible?
I can't even imagine. So this is my own personal thing.
Yeah. Well, because you have a kid, T, so you.
Well, no, now I'm talking about me as a kid.
Oh yeah.
Like
yeah.
if I put myself in these kids' shoes, it would never even occur to me to speak to my parents the way I hear some of these.
Yeah.
Like it just wouldn't even register that I could say something like that to my dad or my mom. I would have been smacked into next week.
Yeah.
I mean, I'm definitely not advocating for corporal punishment.
No, but I mean,
but you knew. I mean, it was
yeah.
just a look that they gave you.
Yes.
It wasn't even like there was violence.
There's a lot.
It's a look like you are not. What? Who are you to tell me what?
Yeah.
So I can't relate to these kids.
Yeah. And I mean, obviously, these kids have a lot of underlying trauma and family component. I try to tell myself that, like, there's kids are still respectful of authority because, like, where we work, we just, like, see it so little, Like, even the kids in the room, they'll be swaying around. Yeah, I don't really care. Like, even towards you, they have, like, complete disregard.
Right, disrespect.
And so then we indirectly turn into the parents, right? So it's like I tell the parents, I'm like, well, if they haven't gone to school in 3 months, why are there video game systems in their room? Why is there television? Why is there internet? I was like, you need to make it as uncomfortable as possible.
Right. They have no incentive to change if you're just going to give them everything they want.
Yeah, and call the police. Like, I mean, they're not doing their job or their role as a child, so as a teenager. So, and again, those aren't fun conversations, but it's just the reality because there's only so much from an emergency department that we could do in that moment. I mean, I'm glad that they're there. But it's sort of trying to help them navigate. And I feel like everyone, the parents, us, even the child, like, we kind of sense I don't want to say the lack of resources, but just, like, maybe somewhat the lack of access, you know?
The inevitability that there's nothing we can do.
Yeah, to some degree. It's like a little bit of, like...
some soul-searching. What do you need to do to change this child's behavior?
Yeah.
These parents are busy. They're doing things.
Yeah, I mean...
It's hard to believe that something is really wrong with your child.
Yeah.
And why they're behaving this way.
I mean, I've had numerous cases of parents saying that they have eviction notices, they can't work because their kids are so dysregulated. I mean, at that point, I'm like, you know what? Even if it's behavioral, I'm going to admit you. Because, like, if the parents can't even work and they're at risk of homelessness, I'm like... Come on, kid. You know what I mean? You got to, like, step up a little. But those cases are tough for us. And so, and then it comes to the other issue on the other side of that is then when we do admit those kids for behavioral issues, sometimes they get boarded for a very long time. And that's something that's in the back of our minds,
Also, like, how vulnerable the children or the adults are to being manipulated by some people. Like if somebody has a very serious personality disorder, you don't necessarily want them to be around, people who are psychotic or who are very just emotionally vulnerable that could be taken advantage of by this person. Yeah. So, antisocial personalities, we really do try to avoid at all costs, unless they have a true, psychiatric or, because, psychopaths have feelings too.
Yeah, right.
But it's rare
they may not care about yours, but they have theirs.
And they do not know how to deal with them. So it's rare that we keep them, but we do.
Yeah.
We do see them a lot and try to avoid them corrupting the children.
Yeah. Well, it's interesting you bring that up. I mean, I don't have this conversation often, but if it's kind of a child who is a little bit naive, a little bit of a follower, they're really not doing too bad from a mental health perspective. I mean, sometimes I will tell parents, like, if we admit, you do have to think of the kids that they're going to be around.
What they're going to hear.
What you're going to hear and what you're going to be influenced by. Because sometimes parents will tell me, like, their kid has picked up behaviors they didn't have before. And it's kind of like, well, they were in an environment where they were more exposed to things. And, inpatient, they do the best they can with the staff and to keep things orderly. But I mean, the kids talk to each other all day, so I mean, you can only control that to some degree, you know. So that's kind of a tough thing too. We're just going down a rabbit hole today, T.
Well, we're just talking about our experience. These are things that we go through, the decisions we have to make, and how we are counting the costs of, whether to let somebody go home or keep them.
Yeah.
A lot goes into those decisions. But we're always glad when people come and they needed to come. Because that's really why we're there, is to give people some kind of hope and some kind of guidance where they can go to keep getting better.
Yeah. And I want to give our hospital system a lot of credit, because we do have like some very nice inpatient units that we have created, probably the best in the area. And so for adults, it's nice because we do have this place that has such a good reputation and provides really great treatment. So it's just the process of getting them there. But I mean, we really do have that, and it's a nice thing, right? That a lot of other systems don't have. And then, we're kind of working on the child side. I think there's like a dedicated child hospital for mental health that's being built currently. So hopefully that'll open some doors. But yeah, I think honestly...
There we go. There's the answer to that question. Why don't they pour more
resources?
They are. It takes a long time to see it come to fruition.
And I think that's more of it's a nationwide issue. Sometimes I will have parents though that will come from like a different state where I know there's more access, and then they're like, "There's nothing here," and I'm like, "I'm sorry."
We're doing the best we can.
Right? It's like, even for people to think about. I mean, policy heavily does affect even the way physicians work, and even the corporations within that system. So it's kind of like a little bit of what's...
I know there are mental health, especially in leadership, advocates that go to like not Congress, but like state Senate meetings and congressional meetings and hearings. They really do advocate for more services. I think that's part of the reason why we have that facility, is because people worked hard behind the scenes to try to get these lawmakers to know what was going on.
Yeah.
So, we definitely try to advocate for our people.
And I think the pandemic also like really just increased some difficulty in individuals and our need. I actually have a stat about that. So for pediatric patients that require mental health evaluations, it jumped by 65% after the pandemic. So like in 2021, 2022. I don't know if that's gone back down again since then.
Kids were really struggling.
Yeah.
That took, taking that year out of their life, or 9 months or whatever, how long it was, that interrupted their flow of learning, how they interacted with other people. Those are critical years.
I know.
Critical time.
Yeah, I mean, think about being kind of in your formative years, having 3 years being at home, and then having exposure to other kids, and then being thrust back into the schedule. I mean, it would be a hard adjustment, and it was,
and it is still.
And it's still, yeah. I kind of even see it a little bit. I would say, like, I have some college-age family members that were in college currently. And I can just tell their experience has been so much different than, like, let's say what we experienced, right? Because, like, we didn't have a pandemic to worry about. And so it just kind of, like, I can tell they were more isolated in college, if that makes sense.
Yeah. Can't even imagine.
Yeah, right? It's like, come on now.
I'd be everywhere in college.
I'd be like, redo.
Yeah.
So T, I think that's why, I said this might be a little bit of a bad shrink episode.
No, this is good. We're humans.
True.
We have feelings.
Are we?
I mean, I am.
I'm a mental health robot, okay? I have no feelings.
Produced by AI. No, we go through stuff.
Yeah.
We're not always perfect. We mess up all the time. We make mistakes, just like, other people. But we're just trying to get there, together.
Collectively.
Yeah, get it together. And it's good to have, colleagues like you that we can, vent with and relate to, because we're all just going through this together.
Yeah.
So I'm grateful.
Yeah, for sure. Me too.
You're a good shrink.
Oh, you're an amazing shrink, T, okay? Really are. Because honestly, your positivity is like so refreshing. I mean, it really is.
What's the alternative? I could just stay in the dumps.
Right?
Worrying about every little thing.
Hey.
And I do sometimes, but I remind myself what it's all about.
Well, I guess wrapping up here, is there anything you want to bring up off topic or anything?
Just about like our assessments. So just don't be scared. If you have to come into a mental health emergency room, part of the reason why we did this episode is so you could just have a picture of kind of what it would be like. And, we don't bite. We do ask a lot of questions, but that's because we want to really understand why you came. We don't want to miss the reason that you came because we think it's something when it's really something else.
Yeah.
So if you have to come to an emergency room to talk to one of us, be sure to come prepared to be honest and, leave it all on the table. Tell us what's going on and we'll do our best to help.
Oh, that's great. And it's true. To contradict that, I'm in my villain era. I'm like,
Your villain era.
I'm in my villain era. Keep your ass at home, okay? That's a complete joke.
Wow.
That's funny. But yeah, so
what about you? You have any tips?
Honestly, you summarized it really well. And I think it's a field that was growing, and we really enjoy, and we try our best, and so that's why we have sometimes our frustrations because we just won't see how things could be better, But we really do every day. Sometimes I'm like, man, I think I really you really make an impact, And I'm kind of in a little stretch right now because I had a vacation a couple weeks ago, so I've been working a lot more, and so...
I think I'm off 5 days this month.
Oh my goodness. That's
so I can relate. So.
Yeah. So, I think just thinking of ways that I try to make my life a little bit more streamlined and easier and to feel lighter, I spend a lot more time in between my shifts with friends, whether it's brunch or lunch or dinner, just depending on my schedule, I make sure to keep up my workout routine, and then also watch my trash reality TV.
Absolutely.
So.
Good.
Yeah.
Keep it up.
Cool. All right.
We'll see you next time.
See you next time.
Thanks for hanging with us today.
Thanks, everyone.